Chronic obstructive pulmonary disease, or COPD, is a progressive, largely irreversible airflow syndrome. The lungs quite literally lose their elasticity and struggle to pump air. Because we cannot reverse this damage, the clinical goal is to slow the inevitable decline. Clinicians often feel pressure to prescribe maintenance inhalers at the first sign of breathlessness. However, skipping baseline checks can lead to prescribing long-term medication for a condition the patient doesn't actually have, while potentially overlooking a hidden malignancy or other cardiac causes. Step 0 of the NICE pathway requires diagnostic certainty. While you might suspect COPD based on symptoms like a chronic cough or smoking history, you must confirm it using post-bronchodilator spirometry to prove the presence of airflow obstruction. This diagram illustrates a crucial balance in management. On one side, spirometry confirms the diagnosis. But to judge the actual severity of the patient's daily struggle, we look at the other side of the scale, the MRC dyspnea scale. Lung function numbers alone rarely tell you how breathlessness limits their life. Supporting this diagnostic process are 3 mandatory baseline checks. Before escalating to long-term drugs, NICE requires you to document BMI, verify inhaler technique, and provide support for smoking cessation. This baseline ensures that any subsequent drug escalation is built on a correct diagnosis, and that the patient is physically capable of using the treatment they are about to receive. With the foundation set, Step 1 provides a short-acting bronchodilator, either a SABA or a SAMA. This is as-needed therapy, intended for initial, empirical relief of symptoms as they occur. Monitoring success at this level involves more than lung function tests. You assess the patient based on their daily symptom burden, their overall quality of life, and their ability to complete daily exercise. Specific triggers signal when it's time to move up the ladder. If a patient wakes breathless, experiencing ongoing exacerbations, or hitting functional limits despite an optimized Step 0, short-acting relief is no longer enough. When a patient hits these limits, the clinical focus must pivot toward building a long-acting foundation to stabilize the disease. Step 2 introduces long-acting inhalers, but the pathway splits into 2 distinct treatment groups at this stage. The choice of inhaler depends on one specific clinical question. Does the patient show evidence of steroid responsiveness or asthmatic features? NICE defines these features through several markers. These include a clinical history of asthma or A to B, significant variability in FEV1 over time, or a blood eosinophil count that suggests an inflammatory component. If the patient has no asthmatic features, the default Step 2 escalation is a combination of 2 long-acting bronchodilators, a LAMA and a LABA. However, if those asthmatic features are present, the